every day. Hospitals, EMS services, and lay people across the globe use Zoll products to save lives.
Thank you very much. It's truly a pleasure to be here. I have no financial conflicts, but I clearly have a love and academic conflict with this topic. But I'm very grateful to Dr. Travers, Dr. Phil, for their review of the clinical data that supports or even calls into question the use of chest compression-only CPR. But I'd like to back up and just tell you where this really came from. In the late 80s, early 1990s, the world experienced a clear downtrend in the number of bystanders willing to do chest compressions. And there were a number of reasons, as you see here. Perhaps they were not trained. When they were trained, it was difficult to do the task. And also there was some reluctance at that time, and perhaps even today, to perform this task, particularly the mouth-to-mouth component. We did a survey in Arizona among 1,000 Arizonans, lay people with interest in medicine, but not doctors or nurses, and we asked them if they'd be willing to do chest compressions plus mouth-to-mouth on a stranger. Only 15% said they would definitely do such. But when we explained that perhaps chest compression only would be as effective, would they be willing to do that? And you can see 70% were willing, a 400% increase. We took that concept and went back to our experimental laboratory. We've had a pig lab to do translational work in CPR now for 40 years in Arizona. And we did 3 groups. The blue group, we did standard CPR, which at that time was 15 compressions and 2 breaths. The red group, we did compression only. And the yellow group, we did what we called then the Tucson technique, which was call 911 when coming upon a stranger with collapse, but doing nothing until the EMS professionals arrived. As you can see, there was no difference in any of the 3 approaches for return of spontaneous circulation, but there was a dramatic difference in 24-hour neurologic normal survival. But that difference did not depend on whether ventilation was performed, but frankly, whether chest compressions were performed. If none of that was done, outcome was poor. But it didn't seem to matter if once compressions were done, whether ventilations were added. We went on to do 6 different studies. A number of swine gave their lives for this work. And we varied the downtime from 30 seconds to 5 minutes of untreated VF. We varied the basic life support period from 7 minutes to 12 minutes. And yet in every study, the results were almost identical. Chest compressions mattered, ventilation did not in this, albeit indirect model. Well, we learned an important lesson. I actually wrote, with numbers of others, but I was the chair of ACLS back in 2000, the guidelines that said when you give breaths, give two breaths, 2 seconds per breath, assuming that meant 4 seconds of interruption of the chest compressions for a single rescuer. Douglas Chamberlain invited me to be part of a group that studied, in fact, chest compression only in real lay people who were willing to be trained. And we trained 500. Half we trained in compression only and half in standard CPR. Again, at that time, 15-to-2 ratio. What we found was remarkable. This was not a survival study. These were mannequin training studies. But we found that no layperson could deliver those 2 breaths in 4 seconds. No matter how often they were trained, and we trained them first at the course, we had them come back for a refresher, but the most exciting part was we went to their home 6 months later. We knocked on their door, and if they were dumb enough to open, We threw the Resusci Annie mannequin on their front room floor and asked them to show us what they would do for their loved one, having been trained a few months before. Every time it took 15 seconds of interruption of compression to go to the mouth, tilt the head back, get a breath, put their lips on that mannequin, blow the breath in, take their lips off, get another breath, put their lips back down. You get the point. When you're doing 15 compressions per minute, you get 9 seconds of continuous blood flow. But then if you interrupt for those 2 breaths and take 16 seconds, you get no blood flow during that time. And in truth, that ends up being less than a third of the time with any blood flow at all. Well, what happens to oxygen? The red line is the famous video shown for years from the 50s of if you're a medical student paralyzed and you don't have breathing, your saturations go down dramatically and fast because you have an intact circulation. But the black line is compression only during ventricular fibrillation. Yes, you will use your oxygen, but you can say even at 10 minutes, it is still adequate to keep you and your cells alive at 50 or 60% saturation. Well, finally, let me just explain the hemodynamic cost of chest compression interruption. This is a cartoon of how blood flow is generated by compressions during the relaxation phase to push flow down your left anterior descending coronary to your capillary bed where the myocyte is fed, and then it returns to the right atrium through the coronary sinus. Your pushing creates a pressure in both of those chambers. It's the gradient between them. If the aortic diastolic pressure is higher than the right atrial diastolic, you will have antegrade flow to your heart. And this is what that looks like. This is 15 compressions. The yellow line is aortic, the green line is right atrium, and here is the diastolic pressure difference. Notice that in those 15 compressions, it builds up. But if you stop compressions for whatever reason, including attempts at mouth-to-mouth, it falls dramatically, and you have to rebuild it each cycle. Here is ideal CPR, 4-second pauses to give the 2 breaths, and you have plenty of compressions and flow. And hence, our early work showed that, in fact, the survival was equal. But what if you realistically pause 16 seconds, what lay people really do? Now notice that 2/3 of the time there's no compression and blood flow is dramatically impacted there. Well, can you teach this to lay people? It takes real effort. I'm going to skip those 2 and just show you some fun slides. That's been the funnest part of our whole program, is reaching out to the layperson and trying to teach them this technique. We've done monthly classes for over 10 years. We put up billboards on the streets, placards at the bus stop. Our most successful was a little bill stuffer teaching compression only in their electric bill once a year. Basketball is king in Tucson, Arizona. And we have taken advantage to do demonstrations. You'll recognize that guy with the gray hair in the middle. 3-pointers is the way to win. And so we put a card on their seat, 15,000 of them. And when there's a 3-point basket, they hold it up. But we put something on the back. How to simply do compression-only CPR. Check, call, and compress. And they actually read it. We use the mascots to kind of convince them. We've taught it in schools. Has it made a difference? It has. This is the increase over the first part of the 2000 era. Not very impressive. Slow gain in who will do CPR. But just like here in Asia, the real gain has been all in chest compression only. Does it make a difference in outcome? Non-randomized, very indirect evidence, downgraded in every schematic, but tripled survival in the state of Arizona. Notice, if you have any rhythm cardiac arrest and you get no bystander help, you may still survive, not very well, but 5% of those people did. When the bystander attempted 30-2, they'd been taught it. I don't know if they really did it or if they really can do it, but when they attempted 30-2, 6% survived. But when they attempted compression only, almost 15% survived. And for better rhythms, witness VF, 17, 19, and 32%. Well, my encouragement to the young physicians and scientists in the audience is never give up, keep going, and eventually you may also get a little flag right on the campus of your wonderful facility here for something that you brought forward. Thank you so very much.